Hi, everyone. This is Kate O'Malley with the California Healthcare Foundation. I want to welcome you to the California POLST eRegistry pilot site, the informational call for people who may be interested in responding or learning more about this effort, and the request for proposal that we currently have in the field. It's just 12 o'clock now, and people are still logging on, so we're just going to give it one more minute, and then we'll start the presentation. And thanks to everyone for being on time. Appreciate that. Okay, we're going to get started. This is Kate O'Malley, once again from the California Healthcare Foundation. Welcome to the webinar. Just to let you know that all the listeners' phones now are on mute, and we will go through the presentation, and then we will have time at the end of the presentation for question and answer. We will also be recording this webinar, and it will be posted on the California Healthcare Foundation website next to or on the same page that the request for proposal for the pilot sites are located. So Lauren, can you advance my slide?
I can't. You're sharing your screen.
Oh. So just briefly, the agenda for our call today, we'll spend a little time on the project team introduction and the project background. What is POLST, which I hope people are somewhat familiar with on the call, a description of the project, the pilot site requirements, the process to respond to the request for proposal, some of the key dates, and then your questions. So the project partners that are working on this are the California Healthcare Foundation, our colleagues at the California Emergency Medical Services Authority, and also the Coalition for Compassionate Care of California. Just to provide some background for the project, at least the California Healthcare Foundation's activity in this space, you may know that we've been supporting POLST in California since 2007, working to a large degree with our key grantee, the Coalition for Compassionate Care of California. That's been working to coordinate activities through the statewide POLST task force, the 25 to 30 local POLST coalitions, and also all the efforts that have taken place on the statewide POLST education program. We've done some background work looking at the effectiveness of our work in California over the years, and in a survey that we did in 2012, we saw a very high awareness and adoption in California in health systems, hospitals, and nursing homes. And we know that the Coalition for Compassionate Care spends a lot of time really doing outreach throughout the state in the healthcare system with healthcare providers to train people on how to train others for appropriate and accurate implementation of the conversation that takes place around POLST, and then the completion of POLST forms. And actually at this point has probably reached over 1,000 healthcare providers as trained trainers related to POLST use in the state. And in 2014, the foundation worked on doing a registry readiness assessment to really look at the best fit technology approaches, some of the operational solutions, and thinking about how a statewide POLST registry might operate in California in the future. And that report is actually on the Foundation's website if that's something you would like to read a bit more about. So we know that other states do have operating registries for their POLST forms. This particular piece of research comes from the Oregon POLST registry, where they were actually able to match the deaths of 18,000 people who died in Oregon who had a POLST form in their registry to actually see the impact of the selections that these individuals made about level of intervention and where they died in Oregon. So in 2010 and 2011, nearly 18,000 people who died in Oregon had a POLST form in the registry. 31% of people who died in Oregon had a POLST form during that time period. And when they looked at the location of death or who died in the hospital, they were able to see, starting from the bottom of the screen, if an individual had selected comfort measures only, and almost 12,000 people selected that, only 6% of them died in the hospital. If a person selected limited treatment, 22% died in the hospital. If there was no POLST form in the registry, and that was 40,000 people, 34% of them died in the hospital. And if they elected full treatment on their POLST form, and this was 1,100 people, 44% of them died in the hospital. So here, looking at evidence from the POLST registry, we can see the correlation between location of death and the intensity of care selected by a person on their POLST form, which gives us a clear picture of the value of collecting and making this information available, and gives us, a lot of impetus and incentive to see if we can have a registry for access to POLST forms in California. So moving forward then in California with POLST and the POLST eRegistry, in October of 2015, Senate Bill 19, authored by Lois Wolk, authorized a POLST pilot project under the aegis of Emergency Medical Services Authority of California. This bill was signed. And one of the important features of the bill is that in the pilot location, it will mandate the submission of completed POLST forms to a registry. Now, we all know the completion of a POLST form is always voluntary, but if a POLST form is completed, then providers who help individuals and families complete the POLST form will be required to submit that form to a registry in the pilot locations. In January through April of 2016, which takes us up to date now, we have been planning a process to conduct a POLST eRegistry pilot with a lot of planning and thinking and brainstorming between the partnership with Emergency Medical Services Authority and the Coalition for Compassionate Care. And we have or in the process of releasing 3 requests for proposal. One to technology vendors, which is actually in the field and is being considered by many of our vendor colleagues. The one for pilot site or pilot sites, which is the subject of this call. And then we're also looking for an evaluator to help us understand the impact of an ePOLST registry in its pilot form. And then in July of 2016, pending the approval of the California Healthcare Foundation Board, we anticipate making awards for pilot project grantees. So this would allow us then to initiate work with vendors, with the pilot sites, and also with the evaluator. So just briefly, the POLST eRegistry pilot project. We have our project partners, we have pilot sites that we would be working with, technology vendors that we would be working with, and also an external evaluator. And as part of this process, we anticipate that the pilot sites would be agreeing to participate in a 3 to 3.5 year POLST registry pilot period beginning in September of 2016 through December of 2019, really to test, to implement, and to maintain a POLST registry. And really what the overall aim of the project is to provide ease in storing and retrieval of POLST data to a spectrum of emergency and other providers, so that when it's required at the point of care, when decisions need to be known about intensity of care, then these wishes are rapidly retrieved and reliably visible and honored by those managing the emergent medical situation. So the aim of all of this work is to really make patients' wishes about intensity of care rapidly available when they're most needed for decision making. So when we're thinking about pilot sites, and this is also referenced in the legislation as well, the pilot site can be one of two types of pilots. So it could be a coalition of health providers in a geographic region, or it could be a health system with a network of existing relationships. No matter how the pilot site is really ultimately defined, it really will need to include all of the key players that would be completing POLST forms and also using POLST forms. So the coalition, either a geographic coalition or a health system network, would need to include nursing homes, hospitals, hospice partners, and health system partners. And then on the side of accessing, would also need to be able to integrate emergency service personnel, ambulance transport companies, emergency rooms, and also intensive care units, who we know from our colleagues in Oregon also seek information that's captured on POLST forms. So that's what a pilot site would look like. When we think about the POLST eRegistry technical overview, this may look kind of busy, and I'm sure it does, and there's additional information in the request for proposal for pilot sites that goes into greater detail about what the technical overview consists of. We're not going to take time on the call to dig too deeply into that, but I would like to call out that there are 3 modules related to how we see the eRegistry technology actually functioning. The POLST input module is where individuals, healthcare providers, and health systems who work with patients and family members to complete a POLST form, that consists of the POLST input module. So completers of POLST forms in the pilot site, even though the completion is voluntary, the submission of a form is mandatory, could use a variety of ways to take the POLST form and put it into the cloud-based POLST registry by fax, by paper, or by mail that is scanned or sent with an email attachment. And the technology would be able to capture and digitize the information on the POLST form for storage into the registry. So the second module is the processing and storage module for the POLST forms after they've been completed and signed, and then they would be stored in a cloud-based POLST registry. The third piece of the module would be the POLST retrieval module, which allows for POLST access at the point of care, whether it's through emergency medical services authority providers in the field or emergency room providers who want to look up, verify, is there a POLST form and what does it say? That would be the module that would help that ease of retrieval and the accurate matching of the POLST form that's in the registry with the person who is receiving care. So just another way of really looking at this in terms of the POLST eRegistry pilot site roles and responsibilities. So the pilot site on the input side would be responsible for submitting POLST form information into the eRegistry. So this submission could be by mailing, scanning, email, or faxing the paper forms, and then also modifying the forms by either canceling or updating as new forms are created. So the intention is always to have the most accurate and current POLST form available in the registry. We do know that people change their minds about intensity of interventions over time, and there needs to be a way to capture those changed POLST forms submit them to the registry, and make sure that there's only one source of truth for that particular person at that particular time related to their POLST decisions. And the pilot sites would also be responsible for retrieving the POLST form or accessing the electronic POLST information. So some of the functions here would be to facilitate integration of the POLST eRegistry with any pilot site health information technology systems or health information exchanges if that's applicable. And then to make POLST information really available to users of authorized medical and public health information systems using API connectivity to retrieve the forms. And then also to incorporate access and retrieval of POLST forms from the registry by EMS providers, emergency room departments, ICU, into workflow so that there's timely access at the point of care by first responders, ambulance transport services, and emergency departments or ICUs. So that's basically the flow of information in, storage, and access in those three modules. The pilot project timeline, there are 3 phases to the pilot project. The first phase we're calling the initial implementation, which would start in September through December. So the 4 months towards the end of the year. And the activities that would take place during those 4 months would be to really establish how forms get in and how they're retrieved and connect the providers in the pilot to the POLST eRegistry, which will be being built by the technology vendors, to test whether or not all the connections are working. So if you can imagine, let's say, there are 20 to 25 nursing homes in our pilot location. We know that nursing home providers will need to have a way to input and access forms. So the way that that gets set up and the connectivity they have to the POLST registry will be tested. And then the technology integration will also take place during that time. Our vision for the technology solution is that it'll be the integration of existing efforts to capture form data electronically and to move it between different types of software. So we'll be testing all that integration of that technology. We'll be prepared to actually go live and actually see, can you get forms in, store them, and get them out. And a key part of this in the pilot location will be a lot of provider POLST eRegistry education to let people know what the goals are of this effort, to ensure providers understand the requirements to submit forms, how they would actually do it, and provide a lot of support and education to all the providers who complete POLST forms with patients in the pilot site location. And then they'll be reporting on metrics for the evaluation period related to connectivity, related to access challenges and solutions, and then provide feedback to the guidelines submitted to the Emergency Medical Services Authority Commission. So part of the legislation requires EMS to provide guidelines to the field related to security of the data and transmission challenges and quality challenges and matching and things like that. So those guidelines will be developed and available in September, and then during the implementation phase, we'll be able to look at the guidelines and get a sense of, as we're starting this up, how well are we doing with the guidelines that have been approved by EMSA. So after the initial implementation, where the technology is established and we've been able to prove that we can actually plug into it and get forms from it, then we'll go into 18 months of phase 2 implementation and monitoring. And during that time period, we'll be integrating the POLST eRegistry submission use into POLST user workflows. So again, using our example of our nursing home colleagues or hospital colleagues or physicians in private practice or hospice providers, when they complete a POLST form with patients and families and it's signed, how do they submit that to the registry, making sure that it is integrated into that we understand and we create mechanisms that integrate it into the normal workflow in those particular settings. And then reporting on metrics for the evaluation period. So, how many forms are being completed, how many are, how they're being submitted, how accurate are they, how many errors are we finding. Through our evaluator, we will be developing a series of metrics for us to know as we go along how effective we are in capturing, storing, and retrieving POLST forms through the eRegistry. We'll also look for opportunities from the evaluation and the data collection for continuous quality improvement throughout that 18-month period. If we're finding errors, for example, or if we're seeing that, let's say, for example, there's 25 nursing homes in a particular pilot area and half of them haven't submitted a POLST form, then we may think, well, POLST form is voluntary, but nursing homes do have people in them who would be appropriate for POLST. So let's find out if there's a problem here or a challenge we can solve. So there are opportunities for continuous quality improvement throughout that 18-month period to make sure that we're capturing the forms correctly and having access to them appropriately to EMS, ambulance, ER, and ICU. And then there'll also be opportunities for targeted POLST eRegistry education. As I mentioned, if we're seeing areas where there are errors or lots of POLST forms or not enough POLST forms, or the volumes that we're seeing aren't what we are possibly projecting, then we would have an opportunity for working with providers to help understand what's happening in the field and if there are ways in which we can make the process easier, smoother, more appropriate. Then our phase 3 phase would be a maintenance phase, again, another 18 months, where all the things that we're doing in the implementation and monitoring phase, we would still have an eye on them for ongoing maintenance of the eRegistry and continuing with our CQI efforts as well. So in thinking about the POLST eRegistry readiness, we gave some thought to, with the end goal in mind of having voluntarily completed POLST forms consistently submitted to a registry with ease of access. When we're thinking about where we could find a pilot that would be ready to go and ready to participate starting in September, there's a couple of things that came to mind. And these are some evidence of POLST form usage and awareness. So we would count on the knowledge and skills of our colleagues at the Coalition for Compassionate Care about knowing which coalitions are really active and involved, and looking at some of the data from surveys that we've done about nursing homes and health systems that are involved, and really find a pilot location where we know there's evidence of POLST usage and awareness in that geographic location or in that particular health system. And then looking at an estimate of the completed POLST forms entering into the registry. So part of the test of the registry will just be, can we connect all of this technology and make it all flow? And that's an important test. And then also there has to be a volume test as well. So we want to have a sufficient volume of forms in the registry to really give us some idea that if EMS or emergency rooms are looking for POLST forms in a registry, that there's enough in there to actually provide that opportunity to actually match the form with the individual at the point of care. So that's an important piece for us to know as we're looking for potentially successful pilot locations. And then also the alignment and overlap of the POLST eRegistry with other health information technology initiatives that may be happening in that particular location. Because that then again gives us that sense that there is a technology sensibility in this particular area, and there's a there for people to work with related to the integration of technology and POLST. And then also that the pilot site has an understanding of POLST eRegistry workflow needs within the pilot site organization. So many organizations will need to come together to have this be a successful pilot, thinking again of locations where POLST forms are completed, in physician offices, in hospice locations, in hospitals, and in nursing homes. Then each one has their separate workflow and their separate challenges within their operational capacity. So a pilot site that can reference an understanding of how the implementation efforts in each of those locations might need to be tailored and might need to be appropriately configured would be a helpful thing to understand in the response. One thing to mention is that there is a report on the California Healthcare Foundation website entitled Uneven Terrain, and we published this last year, and it actually goes county by county, looking at the number of deaths in each county in the year 2014, looking at the cause of death of the most common conditions that might indicate that a person would benefit from palliative care, and there's probably an overlap in that population with people who would benefit from the voluntary completion of a POLST form. So that gives a clue to us as to the potential volume for POLST forms in a particular county, and something that is you're thinking about if you're responding to the RFP, you might want to be aware of as well. So for purpose of just helping people think about the volume of forms and the size of a geographic location or a system responder, we have an example of a potential POLST pilot community, what it might look like. This is not to say this is the community which we're looking to support for the pilot, but this again gives us a good sense of the volume and perhaps the complexity of pulling this together in a system level or at a geographic level that will give us a sense of a true test of a pilot. So if we were to say, let's say there's 1.5 million people, it's 1,000 square miles, the range of providers engaged, again, to get a sense of the complexity of the engagement, some medical groups, hospitals, nursing facilities, and hospice programs, all potential POLST completer locations would need to be engaged in this awareness campaign, workflow issue, completion of forms, submission of forms, and then also the technology integration to get the forms into the cloud-based registry. And then thinking about who the users might be, again, in a geographic location. Let's say there were 10 emergency fire substations, 1 911 responder, 10 ambulance medical transport companies. That would give you a sense, again, on the user side where the connections would need to be and the education outreach would need to be. And then thinking about how many deaths might have happened in that county in 2014 would be a good thing to know. Let's say there's about 10,000. So estimating the palliative care need might be about 7,500 people. So as we thought about this, we looked at a range and an annual estimate of voluntary POLST form completion in a pilot site of this configuration. We're looking at the expected range would be between 2,500 and 10,000 completed POLST forms. And it's a little challenging to drill down too much closer to that, although we'd be happy in the responses to hear your analysis and how you come about thinking about estimating the number of POLST forms. But looking again, thinking about people who would have a palliative care need and thinking that might be a group of people with serious illness, and it might be an appropriate group for the completion of POLST forms. And then, of course, thinking about what are the staffing requirements for this particular kind of work. We suspect that the staffing requirements would change across the intensity of effort across the 3 phases of the pilot. So again, thinking back, phase 1, the initial implementation towards the end of this year, the 4 months at the end of the year. Then phase 2, about 18 months, January 2017 through June of 2018. And then phase 3, the maintenance phase, July, another 18-month period through the end of December 2019. So this will be one of the, challenges in thinking through responding to the proposal, thinking about how much project oversight may be required, how much project management, data collection and monitoring, and then health information technology systems and support. And the RFP provides a little bit more guidance about how to think about that. And also it's important to know that at the project management level, the California Healthcare Foundation will continue to work with our partners, the Coalition for Compassionate Care, on education and outreach in the pilot community, and with EMSA in terms of continuing to cultivate relationships with the EMSA responders and segment of the pilot community, and also continuing to provide technical assistance in the technology piece and the project management piece as well. So we will continue to stay very involved with the pilot site locations in terms of oversight, project management, and technical assistance and outreach to the provider community with education. And at the same time, we won't be in the community where these pilot projects are taking place. So it's important then to think through, if you are working with multiple providers in the community, what would it take to bring them together, stay in touch with them, identify problems, and work with our state-level project management to really address challenges and smooth the project as we move through it. So in terms of the pilot site and the application budget and the funding, the grant funding for this effort on the pilot side is not determined at this point because many things will impact the amount of money that may be required at the pilot site. If it's a small location that is selected for this work, the needs in a smaller location for project management and coordination and outreach and education and problem solving might be less than at a larger site. So we were reluctant to say a budget figure at the very beginning of this. We really want to see that the sites, pilot sites who respond to the proposal have given some thought in these categories about what you think it's really going to take, excuse me, to do this. I think one thing we do know is that from a foundation, the funder perspective, we are the sole funder at this time, and there's many different aspects to this work, and so and many different costs associated with those different aspects. So from the foundation's perspective, preference would be given to pilot sites with lean implementation methods, plans for low-cost maintenance, and the ability to pitch in-kind support, which is described in the budget. And then the number of pilot sites we feel will actually be able to support will depend somewhat on the proposed funding that's required to support them over time. We're hoping, my personal hope is that we can work with at least 2. The more we have, the more we'll learn. But I think having 2 pilot sites would be optimal for learning at this point in the development in California. But we'll see again what the budgets come back and what they look like. We do require in-kind support in the pilot locations of 25% of the total budget is in-kind support, and the proposal itself has more details about what we consider to be in-kind support, but this could be project management time that's allocated from an organization that is not part of the budget that's presented. The time is not part of the budget presented to the California Healthcare Foundation. And then we do have a budget template that's part of this that we're using. So we're actually looking for the cost of the 3 separate phases, phase 1, phase 2, and phase 3, and then an identification of in-kind support in 4 categories: oversight for the project, what the project management will require at the particular geographic or system level, what data collection and monitoring estimates might be, and then if there's any support required for technology system support. And so the RFP has more details about how you might approach and think about that. So here's the overview of the timeline, also mentioned in called out in the RFP. The proposals are out as of last week. We're on the webinar today. Yay, thank you for joining. We'll be collecting all the questions that come through email and that people ask today, and we'll be posting those answers. The proposals are due at 5 o'clock on April 29th, and then we will spend a couple of weeks reading through and scoring, and then we will notify on May 13th, and then the California Healthcare Foundation Board will consider a proposal for funding in June, and then we anticipate that awards would be made by July 1st of 2016, with a couple of months then to really ramp up for phase 1, which would start in September. So in thinking about how would we select the pilots, differentiate them one from the other, and how would we think about this? Again, thinking that we want to be able to jump into this fairly ready for forms to be submitted as we're testing the connectivity and the input modules of the technology solution. The first thing we'll be looking at is registry readiness. So knowing that a system or a community has evidence that they are using POLST, they understand POLST, there's trainers in their location, they've given us a good estimate of the completed POLST forms that they think may come into the registry, that there's alignment with work that's already underway, and that they've given some thought to the registry workflow needs within the pilot organization, and that's clearly identified in the response. We're also looking at item 2, commitment of the lead organization, the leadership team, and a champion with some accountability, commitment of the provider community. You know, we understand that this will be an important and in some aspects probably a challenging undertaking, and to really have it come through in the response that there is definitely commitment to see this through over all 3 phases will be important in the selection process. It's also important in the selection that we see a breadth of stakeholders across the continuum of care. That includes emergency medical services providers, hospice, nursing homes, hospitals, medical groups, and others that will be providing in-kind support. Absent, you know, the ability to bring all of those groups together under a single umbrella with this purpose in mind, it's unlikely that the volume of forms that's required to go into the registry and access through the registry will give us a good test of what we're really trying to learn. And then we're also, number 4, interested in lean, low-cost maintenance of the POLST registry within the pilot site organization. So this is a 3.5-year project, and the last year it will be important that the registry activities continue. This will be an important time in the future of a potential statewide spread to really have operating some examples of an operating POLST registry available for interested stakeholders to learn from and to really understand the value, and then be persuaded to support additional efforts for a statewide spread of a POLST registry. And then the 5th evaluation criteria is to have POLST coalition resources present in the community with a history of active engagement promoting POLST awareness and adoption. Again, just giving us the confidence in the selection process that we have a community that has awareness of POLST, values POLST, understands the importance of the conversation, the importance of training and providing providers with the resources necessary to base the completion of a POLST form in a good conversation so that there's confidence that the wishes that are captured actually reflect the wishes of the person, and it's grounded in good patient education and provider awareness. So that's an important safeguard that we will be looking for also in the responses. This is probably too busy. I'm not sure how you're looking at this, but we already have some questions here. Initial frequently asked question items about the webinar, and we will definitely have the slides posted on the California Healthcare Foundation website. I'm not going to read these questions because they'll be available for you to read, and I want to make sure in the time remaining that we have time to consider your questions as well. So let's see, do I have another slide here? There is time now for audience questions. I also want to flag that any follow-up questions after the webinar should be submitted to Glenda Paha. Her address is here before the end of the day on April 4th. And then we will capture all the questions from today with a written response and any additional questions that are asked by the close of the day next Monday, and we'll make them available on the Foundation's website by April 6th. So that is the plan for answering questions. So let's see, I'm going to go to questions now. So here's a question. Will the California Healthcare Foundation fund integration costs with EMRs and EPCRs of hospitals, EMS, and SNFs? Fund the integration costs. I'm not sure exactly what you're thinking those costs would be, but in the technology pilot, we are assuming that those costs would be integrated into the cost of establishing the technology solution, and as so, then we would include those costs. We would fund those costs as part of the technology solution. So if I'm understanding your question correctly, then I would say the answer is yes. The second question is, how would the requirement for providers to enter POLST data into the registry be enforced? For the purposes of this pilot, that is not really within the scope of what the pilot is doing. I am not sure that there is an enforcement piece in the legislation itself. I think that this is a challenging question. I mean, you could have POLST forms appropriately completed and not submitted into the registry. I think that one of the remedies that we would have for that would come from the education that we would do to providers in the pilot site about how important it is for the learning that we want to do in this particular effort to make every effort to submit the POLST forms. There would not be an enforcement piece in the pilot. That's not a budget item that we are necessarily considering, and I am not sure how the legislation addresses this particular point. That's the best answer I have at the moment, Jeff. I will ask our colleagues at the coalition to weigh in on this additional response, and if they have more information, it will be posted. It'll be posted on the Q&A. Okay, so here's another question. The legislation requires providers helping a patient complete a POLST form in a pilot area to submit it to the registry. Correct. If a provider is not part of an organization that is participating in a geographic region's pilot site, i.e. an independent sufficient practice, are they still required to submit a POLST form to the registry? That is Does a pilot site need to guarantee 100% provider participation in its geography? I think this relates to Jeff's question earlier, Rim. Does a pilot site need to guarantee 100% provider participation in its geography? I don't know that that is really possible to do that. I think that this is a good faith effort, and in the stronger the pilot site's relationships are in the health systems that are in their pilot area, the more likely it is that they'll have provider participation. But I don't believe that there'd be a way for us to really go back and check to see that every POLST form that's completed actually gets submitted to the registry. Again, this will be part of the pilot site's education outreach. It will be part of a mandate that people are aware that this is required. But again, the enforcement side, I think, is outside the scope of this particular pilot. And again, I'll ask our coalition colleagues to weigh in. Another question from RIM. Will CHCF or the vendors selected to develop the technology for the POLST registry be hosting and operating the solution for use by pilot sites? Or does the budget for pilot sites need to include hosting and operating a local implementation of the technology? CHCF or the vendors will be hosting and operating the solution for the pilot site. So part of phase one will be helping the providers in the pilot site to plug into the web-based technology, but they will not be hosting it themselves. Another question. Are the guidelines from EMSA being developed through an open process with input from providers and other stakeholders, or is input limited to feedback at the end of 2016? I can't speak completely to the EMSA process itself. I do know that the legislation does require for public comment and stakeholder engagement, and we have also had one public awareness overview with the state POLST task force. I know that there will be opportunities for public comment on the EMSA guidelines as they are presented to the EMSA Commission in September. So that much I do know from our EMSA colleagues. And with this question, I will also ask for additional input on this question before we post the question. Oh, and here's additional input on the enforcement question from Kelly Queel at the Coalition. The legislation does not have details regarding an enforcement mandate as far as we know. Okay, any other questions? Oh, John, did you want to weigh in on the hosting, the development of technology and hosting that RIM had asked?
I need to see the question. Unfortunately, let me have a quick look here. Is that the question? Will CACF vendors selected to develop the technology for POLST registry to be hosting and operating the solutions for use by pilot sites? So the vendors are going. So it's going to be a cloud-based solution that we are looking to the vendors to host and operate, and we aren't looking for pilot sites to be doing any of that. So I think you've covered it for the most part, Kate, based on what you last stated.
Okay. All right. Any other questions? Well, we are open for questions until the end of the day on Monday, April 4th. And if we get any additional questions, we will respond. And we will also capture these questions in our written responses. and post them on the Foundation website for your perusal and for your edification. And without seeing any other questions, I just want to thank everyone for taking the time to hear more about the RFP opportunity for a pilot site. And we look forward to reading lots of juicy and interesting proposals. So thank you very much.